But by way of introduction, first of all, so you know who I am, I'm Helen Ashdown. I'm a GP, still a jobbing GP in Oxford city centre, but working very much with an interest in respiratory medicine and in novel diagnostic technologies. And I'm based in Oxford doing research into novel health technologies in the NIHR HealthTech Research Centre. And I've been very lucky to work with LifeArc on a few projects, which has been absolutely brilliant. But what I wanted to, obviously we've been talking about PCD, and I think that PCD is a very good example of a rare disease presenting to primary care, but it's not the only disease where there are delayed diagnoses. So what I really want to do is draw on your experience, the experiences of other people, Abdullah's experiences, who was going to be here but can't talk, to really look at how things could be improved and how innovation and research could help in that area. So you've already talked a bit about PCD and given a summary of that, but what I just wanted you to do in just a sort of 1 minute was just explain what is PCD and how does it affect people's lives? Kind of data. You were telling me earlier about the impact day to day it has on you, and that was one thing you didn't necessarily talk about before.
Yeah, so the typical presentation of PCD is recurrent respiratory infections, recurrent ear infections, recurrent sinus infections, upper and lower airway infections. 50% of people, including myself, have their organs on the opposite side, so heart's on the right side. And there are a variety of other sort of things that come into play. So some people have polysplenia, asplenia. There's lots of complicating factors that many people have. It's a autosomal recessive disease, so both parents have to be carriers, and it's extremely heterogeneous. So there are over 56 genes, I think, I'm looking at Debbie for the nod, over 56 genes now that have been identified as causing PCD, but that only accounts for 70% of diagnosed cases. So it's quite complicated to diagnose. Typically, it involves having a cilia biopsy, which is like a mascara wand up the nose. And they look at that under the microscope, look at the ultrastructure of the cilia to see whether that's normal. And then I've been part recently of the European Respiratory Society and American Thoracic Society Joint Diagnostic Guideline. And so now we're also looking at, it is recommended that genetics are also done to try and pick up more people with PCD. And the prevalence of it is about 1 in 7,500 people in general in the UK, but it has a much higher prevalence in certain communities, particularly where there are closer links between marriages, so consanguineous communities. So we think that in Bradford, there was a good piece of work that showed that about 1 in 2,000 people in Bradford have PCD. It's really complicated because it affects lots of different communities with lots of different cultural barriers to getting a diagnosis. And I think this is something that actually really plays into the primary care setting as well.
Yeah, absolutely. And why is early diagnosis important? Why does delayed diagnosis actually matter?
So from my own perspective, I think I'd both have all of my lungs still if I'd been diagnosed when I was born. I ended up having half of my lung taken out when I was 20 because the damage was so bad. And so early diagnosis is crucial to better long-term outcomes in PCD. And I find it quite hard, you can probably hear how wheezy I am today, I find it quite hard to really stress this because we don't quite have all the data that we need to say, the robust data to say if you don't get an early diagnosis, you are going to end up on a transplant list, or you are going to, have a much poorer quality of life than you otherwise would have. But we do know, and we're increasingly getting information that tells us that's the case. They used to compare PCD to cystic fibrosis, which is something that is challenging in both communities because they're not the same disease at all. And PCD used to be seen as the better kind of, the healthier cousin of cystic fibrosis, which it's not at all. And actually in the era of modulator therapies, I think the things are going to shift very, very rapidly. And my greatest fear is that in this, people with PCD are going to be left behind. And if you don't get an early diagnosis, you are just on a kind of fast track to a much tougher quality of life and everything that comes with that. And I think the economic burden, in addition to the health burden, which is something which we just don't quantify and don't talk about, is huge. And I'm happy to go into that from down the line.
Yeah. Does anyone have a tissue? I've got something in my eye
I
that's
actually
just
do.
screaming.
There's a
I
pack
didn't
in
bring
my
my
bag.
tissues up with me. That would be really
Look,
helpful.
Debbie's got my.
Oh, fantastic.
If
Thank
you've got
you for coming,
PCD, you
Simon.
always have a tissue.
Yeah, well,
because you've always got a
exactly,
runny
exactly.
nose.
Thank you. I'm just aware that my eye is going to run
That's
throughout the
okay.
talk, otherwise it's going to be very, very irritating. So, looking back to the kind of the story of what happened for you, can you tell us about how it presented, what you kind of you or your parents first noticed, and I suppose looking back whether there was any kind of any areas within that where something could have been different?
Yes.
So when you start by just telling us what happened first of all.
So I was born in Aberystwyth in 1992, and I was born at full term, went into respiratory distress. They blue lighted me up to Liverpool because they didn't have the I don't know what they didn't have, but they did that. And they did an X-ray, and they saw that all of my internal organs were on the opposite position, but they flipped the X-ray because they thought that they'd X-rayed on the wrong side. Missed opportunity number one, and number two was the pneumonia that I got quite quickly. We moved to England when I was 4, and by that point I had 2 hearing aids, and monthly infections. I think I was on prophylaxis antibiotics, and I think the GP referred to the paediatrician at that point. And I mentioned this in the last talk, it was chance. The paediatrician at the Peterborough Hospital said, "Oh, I know someone in Leicester who looks at this disease. I think you might have it." Sent me up there, and I was diagnosed then. It's pre-internet, I believe, or I don't know. That shows my age. We didn't have internet, so all my mum had was she went to the library and got this bit out of an encyclopedia, and it was 1 paragraph about PCD, and that's all we lived off until I was about sort of 15, and we didn't know anyone else with the disease. And so it wasn't until I ended up at Cambridge, and I was referred to Papworth Hospital during my university years, and that's actually where for the first time ever, I got proper care, and the difference it made just was totally transformative, and I'll never look back, and I will hold that as the standard by which I want to live by forevermore. But it does feel like a bit of a kind of chance journey, and I speak to dozens of families going through this, and we hear the same thing over and over again, and it doesn't seem to change that much.
And it sounds like to an extent you were lucky that the GP referred you relatively quickly, but obviously you've got the role within PCD support, and that's not necessarily that's not necessarily the story for everybody. And I was really struck by the statistic that you gave us before, that 70% of patients have gone to the doctor or a healthcare professional more than 50 times before they get their diagnosis of PCD.
Yeah, so about 37% of people with PCD in a study from 2016 had gone to the GP over 40 times.
Remember the numbers the wrong way around.
No, sorry. I'm just this is my Bible.
Better than me, yeah, absolutely.
And I think it is getting better in primary care. I think actually GPs now are much more collaborative, they're much more sensitive to rare diseases, and when you are diagnosed, I think I've noticed in sort of the past 10 years the relationship between GPs and myself being able to say, well, I think I need this, and it becomes a much more collaborative relationship. I think people are coming through the system quicker, and we know that because the average age of diagnosis in PCD has lowered, but I sort of stand by my belief that we should know it from birth, because it's there from birth. I think, and if it's there from birth, I think we need to really hold ourselves accountable to not letting these people down, whatever rare disease they have.
Yeah, and I want to focus a little bit on why it takes so long for people to get a diagnosis, and particularly thinking about that primary care aspect of it. And it's not just PCD, so we see this in other more common diseases as well. So for COPD, there's an Asthma Lung UK research, there's one in 4 patients, it's 5 years to get a diagnosis. For 1 in 8, it's a decade to get a diagnosis. A third of the 1.7 million is still underdiagnosed. For breathlessness, a quarter of people take more than 10 years. So it's across chronic respiratory disease that this is an issue. From your perspective and those of other people, what are those kind of initial barriers? Why is primary care the sort of the sticking point to diagnosis?
So I feel bad. I've been so mean to primary care today. It was no surprise that the core 20+5, NHS sort of strategy, that respiratory is in that. I think it's an area that, as we all know, we wouldn't be here today, is chronically underfunded, chronically under-researched. And I guess because of the variability and prevalence of respiratory disease, it is very hard to pin these things down. Then you go to, individuals and the sort of fluctuating symptoms that you see, and then you add in seasonality into these conditions. So, we know that in PCD and like most respiratory diseases, your winter is often more challenging. And how do you differentiate that from a normal person or someone with a different condition? So I think untangling that is really difficult. And then the challenges in primary care of, you've only got a certain amount of time for an appointment. We don't necessarily see the same clinician every time. I love my GP, but she's part-time, so my disease is not part-time. So I think when you try and align all of these things, it does just then become a chance opportunity sometimes. And we spoke a little bit previously, but I think why do we not have a system where it flags, you've come about X, Y, and Z, and together that could suggest this thing. Have you lost me? Maybe it'll come. I can just. Okay, cool. Why does it not flag to and make everyone's lives? Okay, I think I'm gone. Make everyone's lives easier. Make the GP's lives easier by saying, have you considered these things, and show them the pathways that they could go down.
Yeah, we were talking about this before. And I think there is this focus on zebras, and the idea that it's an adage in medical, if medical students of, you hear hooves, thinking of zebras rather than horses, and those rare diseases being the zebras. I think it's wonderful that LifeArc are using that as their imagery. But the problem is that, PCD and other rare respiratory diseases don't present as zebras. They present as a zebra in horses' clothing. And the issue is, picking out what it is about them that makes them clear that they're not actually a horse. And it's not something about that symptom, because actually lots of patients get sinusitis, lots of patients get recurrent respiratory infections and cough and need lots of antibiotics because they've started nursery and they've got an older sibling, and it's the winter and we're post-COVID and there's lots of viruses go around. There's lots of reasons that people will present repeatedly. And I think you're absolutely right that the continuity issue has made that harder for patients to see the same GP, to pick up on the fact that this person's coming back repeatedly. But it's something that data could help with. They could flag and say, have you realised that this patient has had 10 antibiotic courses in the year? Somebody said to me earlier, does that not happen already? And I was like, no, it doesn't.
And I think, I don't know what I'm talking about now. You can hear, okay. I think one of the other problems is, so we're talking about the kind of the clinical features, but actually the mental and emotional toll of repeatedly going to your GP and saying this and that. You either end up feeling neurotic or you give up. And so I've seen it, I've experienced it in my own situation. I've experienced it with my son. And I think it's very easy for people to drop out of the system for years. One of the families that I work with, I found out that they were buying fish antibiotics at one point because they were so sick of going to the GP that they went on on a website and tried to find antibiotics they thought they probably would need. And it wasn't, it's just people are desperate for help, and I think the system is struggling. But I guess if I can ask you, it feels like there's a lot of focus on primary care now, maybe a big spotlight on what primary care can do to kind of fix some of these holes. So in your experience, how's that shaping up?
Yeah, so I think there is absolutely the issue around the kind of point when the patient gets to the GP. I think there's an issue earlier around patients recognising symptoms and that kind of getting in touch with the GP, recognising their symptoms. But then it's around this access to diagnostic testing and what's available. So I brought along a peak flow meter. So spirometry, which is the main test that we use in primary care for respiratory disease, was invented in 1847. And then this peak flow meter was first developed 50 years ago, so half a century ago, and hasn't really changed since. So, when we're relying on that, and there's a lot of issues around interpretation and access and using a very old-fashioned test, and we need to be getting better tests. And we've actually, some of the work that we've been doing around this is looking to do a big needs prioritization project with LifeArc called the Helen project, where we've been looking at unmet needs in chronic respiratory disease that could be met by health technology. And we've worked in partnership with patients, done huge scoping work to look at what are those top 20 needs. And they're not published yet, but the kind of the hot off the press, 4 of the top 20 relate to diagnosis and around identifying patients better. But I think it's not just the diagnostic test, it's also the triage, working out when that patient needs referral and that pattern recognition. And actually LifeArc that Sam referred to, this target product profile work around what a diagnostic test would look like for primary care is really valuable, as well.
And so I know for a while, so I have a spirometer now that I have at home, and it's a really useful way of monitoring when I might be getting ill or when I need to escalate for help. In other respiratory conditions in primary care, are there similar tools that are being rolled out?
Yeah, so there is a lot out there, and one of the reasons we did the Helen work was to look at what actually needs to be developed. And there are new technologies. So I know that Ashdown up here, I work very closely with Tidal Sense, who do capnography for looking at earlier diagnosis of airways disease and looking at tests that we can use in the primary care setting or potentially in the community. The idea of kind of smartphone, Shazam for airways disease, where you can do something using a smartphone. So there's a lot of technology out there. And I think the question now is how we test it. Is how we test it well. And I'm a big advocate of these platform studies that we talked a bit about, where we're not just looking at one test against a standard, but recruiting patients in primary care at the point they first present, before they've started treatment and at the first point of diagnosis, and integrate that in with the clinical pathway, gather lots of data, but look at lots of tests in parallel so that we've got shared outcomes. But there needs to be a lot of, there needs to be the infrastructure for that around the funding and around the, exactly, the kind of data governance aspects of this. But I was really pleased to hear that you said for you, any research would be a good thing.
Yeah, I mean, I've had quite positive experiences of it. But I'm a real skewed example, and so the majority of people don't. The majority of people or patients are not aware of research, let alone something as specific. So I noticed we got the card. I don't know if there's time for any questions.
But, I was going to ask about patients who might find it harder to access testing in your experiences.
So I touched briefly on the British Pakistani population in Bradford, and it works much better when people have a kind of cultural understanding of the population that they're working with. That's not a surprise. But I think actually taking things out of the hospital setting, so we know the NHS is moving more from hospital to community, I think that could be really valuable for communities where they've previously been ostracised by research and healthcare. And that's something that we should all be kind of positive about, and thinking that actually might help improve outcomes for some of these really these populations that are experiencing multiple levels of disadvantage.
Can I finish with a quote from Abdullah's podcast? He says, so if a doctor said to you, you have PCD and you need to get tested, they won't listen to you. But if a person from the place of worship, like the imam or a mosque, from a gurdwara, from a temple, a priest, if someone said to them, PCD exists and this is what it is, and they spoke about it on their, Aslan Friday prayers, people would listen to that and actually accept that, because someone of knowledge has said that, someone they accept to be knowledgeable, even though the person may have no understanding of medical background, but because he said that, they will accept it. And it's one thing people need to understand: to reach those communities, you have to build some more relationship with the centres of those communities. When you build that relationship, you automatically build a relationship with the communities. And I think that's a real key, isn't it, around accessing more people and being able to get those diagnostic tests out there into the communities.